So the goals of this talk are to define skill acquisition and retention, how measuring colonoscopy force is a model for defining skill, and I'll talk a little bit about the role of force application in repetitive use injury, which is, of course, of significant concern. These are my disclosures. The force monitor, there are several patents with a group of outstanding engineers. And clearly by their name, you can tell they're immigrants to the United States, so we benefited from their work. And the work was done under an SBIR grant that we had from NIDDK, of which I was the principal investigator. So we can define a skillful colonoscopy and skill as proficiency, facility, or dexterity that is acquired or developed through training and experience. And you could sort of say, oh yeah, you know, we know that these smiling young men that we all know are excellent endoscopists. But do we really know whether they're excellent endoscopists? How do we actually determine that? And I'll tell you what the initial project was, and Dr. Matar may remember this. We actually surveyed nurses, endoscopy nurses, at a meeting, and asked them if they how they classified their endoscopists. And the survey of about 60 nurses was that only 25% they considered good enough to do their colonoscopies. So that means that 75% of the endoscopists that they work with in the endoscopy suite were maybe good, but not ones that they would go to. So I use this quote from Lord Kelvin, which I think is important to remember. When you measure what you are speaking about and express it in numbers, you know something about it. But when you cannot express it in numbers, your knowledge is of a meager and unsatisfactory kind. And then the second quote is, if you can't measure it, you cannot improve it. And this led to the funded project that I'm going to describe, which I think is a model for understanding how to measure skill quality. It's, you know, we talk about it, but the great challenge, of course, is how to measure it. And in colonoscopy, one parameter is force. So what are the characteristics of a skill? It's learned. You know, it's not innate. There may be some people with a little bit more talent, but it is learned and not innate. It is able to be broken down into explicit steps. It requires practice in order to improve. And there's a specific goal or outcome that is measurable. This is defined by Burgess. Now, remember that practice, if you practice the wrong move, you don't develop skill. And many years ago, I wrote an editorial. They made me change the title, but the title of the editorial was "Even Tiger Woods Takes Lessons." I had to change it to "Even Experts," but I thought it was more impressive if you use Tiger Woods. So the greatest golfer who ever lived, probably, I'm not a golfer, took regular lessons. Now, this is a slide that comes from a training group in England, which I think is critical. And you'll see this part of skill acquisition, then competency, then high level of skill, and then I add this arrow for retirement, which is what I did, when your skill begins to decline. I think it's very important to understand that there's an acquisition phase. That timeline is variable for individuals. The ASG defines it as 300 procedures, colonoscopies, but I defy any of my gastroenterology colleagues to believe that after 300 colonoscopies, they would let one of their fellows do theirs. So let's talk about a little bit about the model, some sort of abstract concept of the what we do when we do colonoscopy. So the endoscopist basically applies force and direction, and the patient who happens to have a colon has a colon that has a certain level of compliance and a certain anatomy. And we'll review that. And we chose to study force. This is the worst complication you can see of the misapplication of force. There are obviously very few studies that determine how much force you have to apply, but this is a perforation, and you can see the hole right here, and this is what is dreaded. Fortunately, it's fairly infrequent, but it can vary from 1 in 1,000 to 1 in 10,000 in the published literature, and that tells you something about colonoscopy. So we'll talk about the cost of unskilled colonoscopy, just in terms of perforations and pain management. So perforation, we look in 2017, there were 19 million colonoscopies. If we estimated the perforation rate at 1 in 3,000, and the cost per complication, that would mean that there would be 6,333 perforations in the United States. If we estimated the cost to be about $30,000, that's $190 million. Now, the other issue about colonoscopy is pain management. And many of us remember the era of conscious sedation. But if we go to MAC anesthesia, that costs, if the payment is about $300 per case, is about $2.8 billion. And I would say that John Petrini, many, many years ago, published a paper in which he did most of his colonoscopies without any anesthesia. It was a testament to his skill. We actually measured his force application characteristics as part of our work. By the way, please interrupt if you have any questions. So this was the concept that we developed with our engineering partners, which was a device that you could put on around a colonoscope. It would measure applied force. In theory, it would have capability of safeguarding the procedure. That is, when you were doing the procedure, if you exceeded certain forces, you would hear an alert. And it was useful as a self-learning or a training tool. This was the concept that we proposed to get our grant. And that the physician feedback that was available could be auditory, visual, and part of a record, part of a report. So the idea was to create the colonoscopy or colonoscope force monitor, which was a handheld force measuring attachment that could be mounted on a standard colonoscope, and the device would measure both radial and longitudinal forces. So push-pull and torque. And this was what was applied by the operator during the manipulation of the colonoscope. This was, I won't go through all of the iterations, but this was the first model that we had. We developed a newer model, and this was the model where we did some of our studies. The original model, Dr. Haddad remembers, was the bulky one. And this is the readout. So this device you would use to grip the instrument. It would send a Bluetooth signal to a computer, which basically recorded insertion, on withdrawal, when the cecum, up to the point where the cecum was reached, so you could change it, and you could see force on the y-axis and time on the x-axis, and you could record 30 instantaneous recordings of force per second. And this is a recording of insertion. This is a typical recording, right? So you can see all these squiggling lines. This is the force, in this case, was up to 25 newtons in forward force, and about 25 newtons or even more, up to 30 newtons pulling back on the instrument. And this is torque in newtons per meter, right? So it's an area calculation. So this is, again, a typical CFM record in which force is measured on the y-axis, the record number, which is the measurement number, on the x-axis, and 10 newtons is equivalent to a kilogram. So if you got up to 20 newtons of force, you actually applied 2 kilograms of force to the colon, to the instrument, and that 2 kilograms would be distributed somewhere along the length of the instrument. We can't define that. So the endoscopist applies very different forces to move through different parts of the colon. And you can see, as any colonoscopist will tell you, more force on insertion, less force on withdrawal. But there is back and forth motion, and there is sometimes an increase in force to move forward, even on withdrawal, because you're going back and forth through segments. And these are torque forces. So we have a system that permits us to record all of the right hand movements of the endoscopist. And these were the parameters that we could calculate. And this was published in Gastrointestinal Endoscopy in 2010. So we could calculate the maximum push force. And these were averaged for 5 readings: the maximum pull force, the maximum clockwise torque, the maximum counterclockwise torque, the mean push-pull force rate. That is how quickly you apply the force. So you could apply it slowly, or you could apply it quickly. Just think of pushing. And the mean torque rate, again, how quickly you turn or how slowly you turn. And then we could also examine calculate the total examination time. Because we were able to get all of this detailed data, we could manipulate it. And this is an example of the complexity using a heat map. And I won't go through this, but it just shows you these are 2 different endoscopists, 2 different colonoscopies. And you can see just by the distribution of force in the XY axis, you can see just by looking at it how different it is. And again, it's just an indication of the complexity of this eye-hand maneuvering. Now, what I'd like to do is take you through sort of the challenges of colonoscopy. These data are provided based on a magnetic detector developed by Olympus, which permits you to see the configuration of the colonoscope inside the colon as you're doing a procedure. And this is the most common. 79% have this kind of configuration. This is the sigmoid going up into the descending colon. But there are alpha loops. So you can see the loop going into the right colon, right pelvis, and then going up. There's a reverse alpha. You'll notice here that the instrument, the colon, is in front, not behind. So the colon actually goes behind the sigmoid, rectosigmoid, and then moves up and then comes down. So you can imagine the maneuvering that you have to do, and even though you can't see this, but you can sense it. This is a counterclockwise spiral that you can encounter. And some of these are modified by patients having previous surgery, hysterectomies, adhesive disease from radiation, or just natural variants. Here's a more complexity. There are deep transverse loops. The transverse colon dips all the way down, or can dip down into the pelvis. And remember, you're pushing, it's like pushing spaghetti. You are pushing this instrument through the colon. This is a gamma loop with a transverse limb. You can see that. Imagine trying to push your way through this area without causing a perforation. This is a reverse splenic flexure loop. So the loop around the splenic flexure comes forward and then goes up. So when we teach colonoscopy, we should be teaching force control and loop management, which are the basis for skill and training. And it's not easy to tell someone how to turn the scope. So typically, most endoscopists and trainees use what I call the blow and push method. You just blow up the colon and then you just push it. And then maybe you tighten, you make it stiffer, you make it less stiff, you push on the belly, you roll them on the back, you roll them on the stomach. You do all kinds of things to try to manage this looping. And again, here's the AP view. This is a lateral view of the way the colon is causing the instrument to loop. So as we all know, the application of force to the colon can be painful. I actually, in my own colonoscopy, at one point, I decided to have a colonoscopy without any sedation. It was not fun because I have a very high splenic flexure. Significant force is applied during colonoscopy at specific location. As we all know, sedation around analgesia is required. Forces were not characterized, and there was no current means for quantitative assessment. Then there's an older study, and now a more recent one on perforation, how much force you had to apply. And that, of course, depends on the compliance of the colon. But generally, it's anywhere from 20 to 35 newtons. So here, again, 10 kilograms is a newton. So here they were able, 2 kilograms is a newton. 10 newtons is a kilogram. So this is 90 newtons. So here are our force measurements, and each bracket is the operator. And this is time derivative. Each is a different case and a different operator. So each operator did 5 cases. Each one of these is a different case. This is a time derivative of force and a time derivative of torque. And what that means is the application of force per unit time. That is how quickly, how fast you push. So you can push like this, or you can push like that. And you can see, it's obvious without looking at the numbers, the variation between operators. This is both for force and for torque. And remember, we have multiple parameters that we're measuring. This is average push-pull force for 6 operators. And you can see the different force rates based on operator. This is a box plot. You can see the variation, tremendous variation. The average time derivative of force and torque displays differences in technique of individual endoscopists. So these are some of our force data. And what you can do with this information is now you can look at the variation among endoscopists and where there's variation. So again, the idea of being able to quantify the levels of significance are high. Maximum push, maximum pull, push-pull rate, how quickly you're applying torque, and the variation among endoscopists in exam time. So you have this cowboy endoscopy or cowgirl endoscopy. If I can get to the cecum in 5 minutes, but there's a price to be paid for that. Highly significant differences among endoscopists. And what you can do with some of the technology is apply mathematical formulations to do grouping, what's called a cluster analysis. And in these 6 endoscopists, you can identify different groups based on these mathematical formulations. So you have clusters. You have this group, endoscopists 1, 2, and 6, endoscopists 4 and 5, and endoscopists 3. So again, you can separate endoscopists into just different groups without making without providing any opinion about what's good or what's bad. The next slide is really the subjective one. So here, this group is now divided based on a scale into low, medium, and high force appliers, or whatever the characteristic is. And I draw your attention to the three groups, the time duration. Now, we're not talking about a colonoscopy that takes a half an hour versus one that takes, insertion takes a half hour versus 10 minutes. The difference is maybe a minute or two in the data. So each of these, you can see group 1 takes a little longer, maximum push is at the lowest level, all low. And group 3, of which there was one endoscopist, it was quick. And, time is money. So you could see it was all medium and high. So each colonoscopy examination is characterized by multiple recorded parameters, and each of these can be used to categorize an endoscopist. So again, we're moving to the concept of making a qualitative assessment of what we want. And I would propose that I'm more interested in having my colonoscopy done by this person, regardless of adenoma detection rate, et cetera. I would prefer that somebody in this group do my procedure. Now, if I'm asleep, that may not matter, but this is my preference. So let's look at some of the other things we can measure when we use technology that gives us quantification. We can divide the colon into 3 zones, 1, 2, and 3. Sigmoid, rectum to descending, descending to transverse, which is a tough corner, getting around here, mid-transverse colon, and then cecum, transverse to cecum. So does it matter? Well, here we now calculated, the answer is yes, but we looked and we calculated then for zone 1, 2, and 3, the maximum push force, the average push force, and the rate at which push and pull are applied. And you can see that as you get deeper into the colon, as you have more mass that you're trying to maneuver around and through, force application increases, regardless of the parameter, whatever way you measure it. So does the operator matter? Well, here, let's take a look at the individual operators for maximum push-pull force, average push force, and average rate, the rate at which it's applied. And what you can notice from these box plots are 2 things. One is there's tremendous variation among endoscopists. And there's tremendous variation within endoscopists. So for the 6 cases, you can see this endoscopist, number 6, has a huge variation in the maximum push force, whereas these 2 endoscopists operate within a narrow range. And I would propose that that's a haptic sense, that these endoscopists begin to sense when they may be pushing too hard, so they change their technique. Whereas this endoscopist is just moving hell-bent for leather. That's my subjective interpretation of these data. So again, it's the variation among endoscopists is significant. Does anesthesia matter? Well, interestingly, in our first observations, which included Georgetown, we thought that anesthesia mattered because at the VA, we were using conscious sedation, and at Georgetown, everybody got monitored anesthesia. But there was a difference. that the Georgetown endoscopists were being performed with a larger diameter scope, and I'm not going to show that data, whereas the colonoscopies done at the VA were done with a thinner diameter scope. And so the force was higher with propofol than with conscious sedation. So we undertook a randomized study. You can't really control it because if you give conscious sedation, the patient is awake or somewhat awake, whereas with propofol, they're completely asleep. So you can't do that. But here, if you look at anesthesia, this is conscious and propofol. And this is the retrospective cohort. And you can see that we thought that for maximum push, with propofol, it was higher. Does the instrument matter? And I mentioned that before. I didn't realize I was going to show you the data, but you can see that the forces are lower with a pediatric or thinner instrument than with an adult. This is for maximum push force and average pull rate. And these patients, the endoscopist was randomized to either use an adult or a pediatric scope. This was done at the VA. So it made a difference. And my hypothesis is that the pediatric scopes are more flexible. So it's harder to apply force. You get more looping, and then you sort of change your maneuvering. But in general, less force is used, although the rate in newtons per second is probably not that different, but it does vary a lot, much more with the adult than with the pediatric. So the instrumentation makes a difference in how force is applied. So we continued to do in this randomized study where we had 70 patients, 33 were female, 37 male, mean age 58.8, mean weight 168.9. For moderate sedation, the average dose of fentanyl was about 108 with about 3.3 of midazolam, which is maybe a little on the high side, but generally pretty standard. And the average propofol dose was about 200 milligrams. And you can see that really there's no difference. So it doesn't matter whether you use propofol or conscious sedation in the primary outcome measure, which is the force different between conscious sedation and propofol. So insert maximum push, insert maximum pull. This is insertion maximum right torque, insertion maximum left torque. Didn't matter, because that's where all the discomfort is on insertion. But here, again, we're confronted by the variation. Does anesthesia matter? It doesn't matter overall in a population, but look at the variation between endoscopists for conscious sedation. Significant variation. And look at what happens when you use propofol. A little bit different. This endoscopist maybe behaves a little bit differently, but this endoscopist is about the same. This endoscopist is a little bit different. This endoscopist varied a little bit more. There's an effect of the device because it's not natural. You're holding the instrument with another instrument, so it does modify things. But here, again, we're confronted by the variation due to the endoscopist. Now, we then undertook a study to look at trainees. This was done by Dr. Endy. This is a multi-center study that we did. And these, we had novice trainees, experienced trainees, so these are first years. These are second and third years, and these are experts, which are the attendings. And you can see that it really depended in terms of the torque. We didn't go into patterns, but just the forces. If we looked at clockwise torque force during colonoscopy by skill, you could see the difference is, but really here to some extent. Again, here on torquing. So understanding how to torque the instrument was really very different among the level of training. So the assumption is that as you improved your skill, you change the way you apply the maximum torque. So again, maximum torque is a haptic phenomenon. You feel the instrument and you feel the amount of force that you're applying. And so as you're more experienced, maybe you say, that feels a little, I'm sensing a little too much, and it's not explicit. So you can see that with experience or with training, the parameters for force application change, as they should. So the result of our studies led us to this concept of we really have to change just the whole setting in which we do endoscopy because of the tremendous variation. We need to develop more uniform training. We need to improve continuing education. That is, you can't just stop when you finish your fellowship. Most of the continuing education programs that we see relate to polyp detection or polyp removal, but not to the execution of endoscopy. And instrumentation. We haven't seen a lot of changes in the structure of a colonoscope over the last 15 to 20 years. There's some variable stiffness, graded stiffness, but there really hasn't been a lot of the development of thinner instrumentation, but there really hasn't been a lot of improvement. There have been attempts at self-driving colonoscopes, but you can see that none of them are in the marketplace. And the goal of all of these, is to reduce pain, to reduce the amount of anesthesia, and theoretically to reduce complications. Fortunately, the main complication of perforation is pretty rare. But again, anesthesia, if you're using conscious sedation, pain, these all should be improved by improving training programs. And the conclusion that I've made as a result of all of this work is that you can do more than just say that, it's like diving, where you have a bunch of judges with cards that stand there watching you do a colonoscopy and say, oh, that's a 10, that's a 7, that's a 5. We don't really quantify colonoscopy technique. We rate fellows, but the use of some sort of force monitoring device does permit you to quantify it. Each colonoscopy and each colonoscopist does have a unique signature. What an appropriate signature is and an inappropriate signature is not undefined. What's clear is that there's too much variation. And the focus of training should be to develop this haptic communication, that the endoscopist really needs to understand how to use what they feel, not just what they see, to optimize performance and to reduce this variation. And I can tell you, having trained many endoscopists, that there's just too much variation. One endoscopist says, well, you have to hang the scope over the stretcher. No, you can't torque. No, you can do this. No, you have to do that. There isn't a consistent process. And this impacts quality assurance. So quality assurance and performance improvement should be designed to improve endoscopic performance, to include the concept of skill, not just adenoma detection rate, not just polyp removal. How slick am I at doing that? But really, how good are you at doing colonoscopy? How well can you execute that? And we had actually proposed building a workstation where you could actually record, analyze, and review a colonoscopy by correlating the images with what was happening during force application. And in fact, again, using mathematical principles, of quantification, this is from a NIST paper, which is the idea that the quality of a product or process has multiple characteristics, with one of them outside of some desired limit that's completely unacceptable. And this was actually applied to characterizing the quality of tires. But you can use it for endoscopy, time to cecum, withdrawal time, pain score, polyp detection, peak force, average force. You can put these into mathematical computations. They're not absolute measures. But when we think about really any kind of skill development, you have to be able to measure an outcome. And this was just one proposal to do this kind of work. So I'm going to stop there and tell you that SBIR grants are designed to create a commercial product. And we had partnerships with Olympus and Pentax. And of course, this never became a commercial product. And the reason it wasn't a commercial product is it needed another 1 or 2 iterations, and it was non-reimbursable. So you couldn't bill for doing force monitoring. And as a result, no one was interested in commercializing this technology. So basically, the force monitors, I have 6 of them sitting in or 4, maybe 4 of them sitting in various closets around Washington, D.C. But it does show you the idea of understanding how you can measure something and really begin to understand how people execute certain kinds of eye-hand skills. Again, a lot is invested in golf, but we don't do, this is not golfing, it's colonoscopy. There's no videos that you can show your golf expert that analyzes your swing. So I'm going to stop here before I talk a little bit about force and repetitive use injury. Otherwise, I'll just move right along.
Any questions? Just a quick question, Louis.
Yeah.
You mentioned, is it innate versus acquired? Some people claim that you can predict from day one which fellow is going to be technically skilled and which fellow would not be as technically skilled. Has this been your observation? Can you tell from the patterns you're measuring?
No, because we don't have longitudinal data. We can do longitudinal data. Look, we know that there are people who have better eye-hand skills than others, but that doesn't mean that you can't train somebody, right? So it's Mike Weinstein likes to talk about handicaps. Not everybody is going to have is going to be a professional golfer, but that doesn't mean that you can't be a very good golfer. So the question is, yes, there are going to be people who are below average. The question is, what's the level of average?
Yeah.
And I think what we need to focus on is really training. And the dilemma that we have is no one has time. If you look at an endoscopy suite, most of the attendings are sitting on their computer answering emails and not standing next to the next to the fellow. And again, this is a problem not in the United States as much, but if you go to other parts of the world, Nib Sahendra is trying to develop training programs in Indonesia and East Asia and South Asia because you don't have fellowship programs. So how do you can sell people a colonoscope, but that doesn't mean that they know how to do colonoscopy. So how do you train people? How do you give them an ongoing or educate them? So I think that I've seen enough people come out of training who've done 1,000 colonoscopies, and they've done 1,000 colonoscopies badly. Now, to unlearn a bad technique is very difficult. So I think, yes, you're going to see people who have better eye-hand skill. Maybe they've been playing video games more. Maybe they're more athletic. I don't know what it is. But you can train everybody to a high level. That's what I believe. You just have to be patient.
All right. Do you have any more slides, Louis?
Yeah, I have a few more.
All
really
right. Why
quickly.
don't you do that, and then we'll take there are a
Yep.
couple of questions in the chat box.
So I'd like to turn my attention to ergonomics. So the force there, it's not just the force. I'm going to deal with force in the application of colonoscopy, but there are issues. So this is, in theory, the ideal structure for an endoscopy suite. But anybody who's been in an endoscopy suite sees people hunched over, bent over, because of the stress and tension that happens when you do difficult cases. It raises stress level, and you have to understand your body's position. This picture is a picture that was shared by Jerry Siegel, who was one of the earliest ERCP endoscopists in New York City. I venture to say he's done 50,000 cases, and he ended up with spinal with fusion surgery as a result of being kind of hunched over. He didn't have a lot of arm stuff, and I'm going to deal with that in the next slide because that really affects women more than men. So you have to understand that a female physician at age 40 has the arm strength of a 70-year-old male. So the forces that female physicians use are in fact much more likely to produce repetitive use injury. So this is Amandeep Shergill. There's just not a lot of data in this because there's not a lot of investment in the technology needed to study this. And it's tricky because you have to have collaboration with industrial hygienists. But let's just look at the anatomy. So this is your right hand that you're doing the colonoscopy with. This is where they put sensors to do EMG. This is where there's typical injuries, right? So tennis elbow, epicondylitis, and decurvain tenosynovitis. And the muscles are the extensor carpi radialis, which is this one, and the abductor pollicis longus. I had to review this. It's not so easy, but these are the muscles that we use. And here are the data. So this is, I think there was 6 colonoscopists that were studied. And this is the force that they used. And this is an industrial hygienist representation. So this is their measures, which are amplitude probability distribution. So each one of these is a percentage. So the number of times that they measured force in excess of 10 newtons. So this is 90% of the time the force was below 10 newtons, 50% of the time the force was below 4 newtons, and 10% of the time the force was below 1 newton. So this is left colon, this is right colon, and this is withdrawal. And you can see that the highest force is not, it doesn't exceed 10 newtons. Remember, 10 newtons is a kilogram. So what they did was they measured force, and there are parameters, right, that are established by the industrial hygienists on whether you exceed a certain amount of force. And you remember from the other slide that I showed you that you can hit 25, 30 newtons. Some endoscopists will reach those forces in order to push things through. So this gives you a sense of what's happening on the muscle, in the muscles, when you're doing insertion, and how many times you exceed certain forces, what percentage of the time you exceed certain forces. And just for those of you who are not colonoscopists, I want to give you the terminology. This is the control section, right? So here you're using the adductor pollicis longus, right? Because you're moving this dial. And if you have a small hand, it's much harder than if you have a large hand. And this is the insertion tube. We measured force along the insertion tube. We did not study this. And this was, when they measured this, I'm going to go through what happened. In the left, and I'll draw your attention to the right, but these are the motions. This is the left hand, so the hand that you use in the control knobs, and you're turning the knob. You're manipulating the dials of the colonoscope, and you can get decurvains, tenosynovitis. And here, this exceeded, in all of the cases, exceeded the action limit, suggesting that you're going to end up with repetitive use injury. This is the left wrist extension, stabilizing the control section of the scope. This is the second and third extensor compartment tenosynovitis of the wrist and tennis elbow developing. And you can see again here, this study demonstrated exceeding force. This is the left side. In the right colon, if you look at the right, you don't actually, except for tennis elbow and tenosynovitis in the wrist, that's the only time that force was exceeded when you're using your right hand to push. So here you have left hand injury. This is right hand injury in wrist and epicondylitis. And this is, of course, dependent on your bone and tendon structure, right? So it's not the same. It's not the same for a male physician or a female physician or certain kinds of physician. And that's why force application becomes critical. How you use force, whether you exceed these thresholds that are defined here. So you have to be aware of that haptic capability. So the conclusion here is that excessive force application poses a risk for overuse injuries. So force is not just a theoretical construct of rating an endoscopist, but for an individual endoscopist, it has significant implication. So if you understand how force is used, you can reduce these risks. The way you stand, where an outside viewer can see that. But the force application of your hands is much more difficult. So skills should include an understanding of harm reduction. We just talked about skill and so, well, I can get to the cecum. But there is a harm reduction that should be incorporated into skill. And again, if we use golf as an analogy, and I'm not a golfer, you can understand that there's a better way to hit the ball so you're not hurting your back and your arms. And that is part of skill training. So my last slide is, some people will use the force, Obi-Wan Kenobi in 1977, and yogurt from Spaceball, and some people use the Schwartz. That's the end of my talk, and I'll be happy to answer any questions.